Hi everyone, it's Tammy Sharrow, and today I'm going to be talking about burns specifically and linking it a little bit more with the age and stage of toddlers. Just to give you a couple of examples from my own personal clinical practice. So thermal burns, I can remember a little boy who his grandmother was cooking bannock in a frying pan on the counter, and he was obviously a toddler and curious and pulled on the cord and pulled and spilled all that hot oil around his neck and his shoulders and his upper body and his arms. Chemical burns. Probably the one that I remember the most was a child that was in an explosion in a meth lab, a 4-year-old, and had significant burns, mostly to the face and the hands. Electrical burns commonly happen when a child might put an electrical cord into their mouth. So whenever we leave a charging cord, say plugged into the wall, children are very curious about that. And there was a case of a toddler who there was simply an iPhone charger and put the end in her mouth and ended up with significant oral and airway burns. And then lastly, radiation. These are burns due to prolonged exposure to ultraviolet rays of the sun or other sources of radiation such as X-ray. Obviously, sunburns are the most common, and they can happen very, very quickly. There was an interesting case of a toddler out without any sunscreen, very hot, and ended up with second-degree burns on the shoulders and the back and whatnot. And the child ended up getting apprehended from the family due to neglect. So let's look at burns by depth of thermal injury. So, old language for burns used to be superficial or first degree, second degree, third degree, that sort of thing. Now we're talking superficial, partial thickness, full thickness burns. So here is an example of a superficial thickness burn. This one could have been due to a chemical burn, like certainly acids that come from diarrhea, things like that could cause a burn here. Could be application of heat, hot water in a bath or something like that. But you can see it's very similar to a sunburn. It's reddened. This type of burn can be painful, and it typically is going to resolve in about I think 5 to 7 days ish, and probably would just be treated with some antibiotic cream, that type of thing. Then next we have partial thickness burn. So this, if you have a look at the picture, it's a little more reddened, and there's obviously evidence of blistering. Here the blister is popped. Once again, this can be quite painful and typically will heal on its own in 10 to 14 days. Doesn't require skin grafting or anything like that. Next is full thickness burn. So you can see the difference in the photo here. And often when we get into extensive burns, there can be a combination of some partial and some full thickness depending on the cause of the burn. But here we've got a very some cherry red. It looks like some whitish areas, maybe even some exudate or pustule type areas. And you can see that this is like chest and neck burn, could be from a flame or a hot liquid or something like that. And typically they say that full thickness burns are not as painful because the nerve endings have been burnt or fried, but rarely do you have only full thickness or only partial thickness burns. There's usually a combination. So in my experience, working a lot of pediatric ICU, most burns patients have pain control issues. Here's another example of a full thickness burn. We get really concerned about the involvement of certain body parts, and here you can see the hand, the black on the fingertips is likely going to mean that those fingertips are going to fall off. But from a functional point of view moving forward, hands are really important for life and dexterity and activities of daily living and what have you. So this is a really, really significant burn that would need some serious rehabilitation. Child abuse burns equate to about up to 25 to 30% of all burns. And typically burns related to child abuse have a very classic or some characteristic appearances. So here, what we can note about these burns is that there's a really clear sort of circumferential border. There's a clear line where the burn starts and stops. And so this is very likely an immersion burn. And that's something that we certainly look for, when kids come to the ER with a burn. And then, of course, with child abuse burns, we're always screening for other injuries that, could occur, because typically there's likely other kinds of maltreatment or abuse going on, not just the burns. This is an example of cigarette burns. So that's probably one of the most common type of burns we see in child abuse. And then here, hot object applied to the soles of the feet. So it could be a spatula or some type of cooking instrument that was heated and then applied to the feet. So once again, we just really would do a very, very thorough assessment and screening for other injuries and whatnot that could be going on in relation to a child that shows up like this. Okay, so let's look a little bit at the pathophysiology of burns, and we're going to focus on moderate to severe burns. These are the kiddies that definitely require the most care and support and sort of compromise. So we're going to look at how the body responds to a burn, the clinical manifestations we might see, and then some generalized clinical therapy, how we're going to treat that. I have a little table here for you, and we're just going to work through these one by one. So top left, the body's initial response to a burn is an increase in capillary permeability. And so fluid rushes from the vessels into the cells, and it results in edema in burned and unburned skin or tissue. And this is where the risk for hypovolemia can occur. When we looked at hypovolemic shock, we knew that fluid movement in relation to burns could set the child up for hypovolemic shock. And another clinical manifestation is poor urine output or oliguria. So our clinical therapy is we need to fluid resuscitate and replace that fluid that's moved from the capillaries into the tissues for a period of time. So typically that fluid moves out, and within sort of typically 48 hours, but somewhere between 24 and 48, it starts to move back in. So we would fluid resuscitate for that critical time when the fluid is moved out. Other body responses then are decreased cardiac output as a result of this fluid shift, but the body responds by trying to increase vascular resistance. If we increase vascular resistance, we might be able to improve, blood flow, blood pressure. So another clinical manifestation is hypovolemia. We're going to see signs and symptoms of poor cap refill. They are often tachycardic, that's that compensatory mechanism, and cool extremities. And so when we see a child progressing from just increased cap permeability and edema to seeing an impact on their cardiac output, we get really serious about fluid resuscitation, and we resuscitate to maintain urinary output within that normal range. And we use that as a parameter to measure our success in fluid resuscitation, obviously along with vital signs, blood pressure, heart rate. Airway inflammation is not an initial response, but it typically occurs in the case where there has been smoke inhalation. And some of the signs we might see is hoarseness or stridor. We might see burns around the face. We might actually see soot in the mouth. And so those would all be things we'd be looking for on initial assessment when the child shows up to emergency. And of course, a burn to the airway is going to cause airway edema, swelling, narrowing, and ultimately the child will be hypoxemic. So this is where we provide supplemental O2, and we may actually need to intubate and ventilate the child. Bone marrow suppression. This can occur in reaction to the burn, and this typically results in anemia. And there can be, we treat that with transfusion of packed red blood cells. It's a little bit of a later response. It's not some of the first things we'll see, but it can occur. The body tends to go into a hypermetabolic state, and that's just the response to the trauma of the burn. And what happens is certainly there can be weight loss and loss of lean body mass. Another thing that can occur is hyperglycemia. And so an important piece of this is a high protein diet. And, initially some of these kids aren't eating, but they would very quickly have a G tube or an NG tube or enteral tube of some sort inserted, and we'd be providing them with a high protein diet. And sometimes in a severe condition, they might have to go on insulin or insulin drip to manage the hyperglycemia. Decreased digestive absorption just comes in relation to the trauma, and of course then there can be nausea, vomiting, a food aversion, and of course actual paralytic ileus where you're not going to be hearing bowel sounds and those types of things. So once again, IV fluids and electrolytes. We might put a nasogastric tube in just to drain the secretions and fluid in the stomach till such time as we have active bowel sounds and can start to feed. Inflammatory response. This can occur, and some of the manifestations we see is fever, tachycardia. We often can have open wounds in relation to the burn, and so we need to care for those wounds in a very precise manner. Sometimes we will have debridement of dead tissue in the burn wound area, excision of full thickness burns. Wound dressings, burn dressings are typically done several times a day, and a severe burn would be on protective isolation to prevent infection. And then this notion of immune suppression that can occur due to bone marrow suppression. A lot of times there's an overproliferation of the white blood cells, and that can also squeeze out things like the production of red blood cells or platelets and those sort of things. So immune suppression can occur, and we would treat these patients with antibiotics. So as I mentioned previously, there is a risk of hypovolemic shock with a thermal injury. And as it says here, a potentially critical condition exists from that extracellular fluid loss, plasma loss due to the burn. So we can end up with decreased volume, decreased cardiac filling. We have a lower end diastolic volume. Ultimately, we're going to have a decreased stroke volume, which ultimately is going to decrease our cardiac output. So our whole focus is really in prevention of hypovolemic shock. So one of the ways to prevent hypovolemic shock is through that fluid resuscitation. So one of the first things we need to do is measure the extent of the burns and the burn severity. So in assessment of the burn, we look at a number of things. One is the depth of the burn, which is largely visual, right? You saw the pictures of, partial thickness, full thickness. Then we're going to look at the percentage of body surface area that's actually burnt. And so there's something called the rule of nines, and there's one for adults and for children. And you can see the different percentages here. For example, the child's palm represents 1% of his or her body surface area. So we look at the areas burned and we add up those numbers, and that gives us a percentage. The 20% of the body surface area is burned. And we also pay attention to specific body parts, such as the face, hands, genitals. Is the burn circumferential? So does the burn go around the entire leg, for example? Because often then there can be, the swelling can be so severe, and it can actually cut off blood supply to that area due to the significance of the edema. And then sometimes we have to go in and do little escherotomies where we actually put little incisions in the limb to release some of that fluid and edema to improve blood flow. So in treatment of major burns, I've listed the sort of priorities of care. And number one is always to stabilize the ABCs. So we always look for indication of respiratory issues. We would look for indication that there could have been smoke inhalation. Is there soot in the mouth? Is there any airway compromise, wheezing, hoarseness, etc.? Any burns to the face or the neck area? Because the swelling can occur in the neck area, and with the child's airway, it can cause compromise as well. So that's our number one. And then number two, we move to managing the fluid shifts to minimize fluid loss. So we're looking for those early signs of hypovolemic shock, and we're using a particular strategy and formula to calculate how much fluid to give this child over a certain period of time. And I'm going to talk about that in a few slides. Some people are surprised that pain comes number three, but we need a patient to be alive, have an airway, and have, a blood pressure and adequate cardiac output first. And so controlling pain sort of comes number three. And I mean, ultimately in a trauma situation in an ER, if a kid comes in with a major burn, a lot of these things are happening at once. So often the amount of pain medication these kids require is high and often well above what we would consider a therapeutic dose. And sometimes we also might include sedation along with pain management from, just having the child relax and lower the stress level and sort of their cognition. Preventing infection and further tissue loss is really critical. So we've lost our skin, our first line of defense. We're at high risk for infection. And so they would be on antibiotics, as I previously mentioned, protective isolation. We would be doing frequent dressing changes, sterile dressing changes, and often debridement, which might be done on the unit if the child is taken to the burn tub for debridement. Sometimes some kids would go to the OR for debridement. Promoting nutrition, important. So initially IV, and then once we have good bowel sounds, it would be followed by enteral or oral feeds, high protein, high calories, so we can prevent that weight loss. And then protein is important for cell development, cell growth, muscle. So it's a really important component in a burn. Aiding range of motion and mobility. So, if you think about that picture of that child's hand who was burnt, how important it would be to maintain range of motion and mobility in all of those limbs. So I can remember working peds ICU, and when we did the dressing changes and opened the wound up, that is often when physiotherapy would come and we'd work with them and do range of motion and mobility multiple times a day, so that we maintain that throughout the healing process. And then number 7, support effective coping. Obviously with children, it can be a very stressful experience, often hospitalized, stressful for parents. A number of burns, sorry, I had to take a drink, end up parents feeling very guilty because a lot of them are accidents that maybe could have been prevented. So there's often a lot of counseling and social support that has to go on. A lot of these kids end up being admitted for a long period of time too. So as I mentioned, fluid replacement therapy goals in moderate to severe burns is to prevent hypovolemic shock and compensate for all the water and sodium loss to the traumatized or burnt tissues into those interstitial spaces. So there's a formula that we use in adults and children, and it's called the Parkland formula. And if you looked it up online, you could actually find a calculator that would calculate this for you. Now, this is just to replace the fluid shift. So we take 4 mils, that's just a standard part of the equation. That doesn't change. We multiply it by the weight of the child and the percentage of body surface area burned. We're going to take that amount. We're going to add what would be considered maintenance fluids for that child, and that is going to equal our 24-hour total fluid replacement. Now, we, with the Parkland formula, we give half of that in the first 8 hours, a quarter in the next 8 hours, and a quarter in the next 8 hours. And then we add the maintenance fluids each time onto that. Then we reassess. We might have to consider plasma replacement if we're not getting the results from the amount of fluid that we're giving. And we always need to really closely monitor electrolytes because there's a lot of shifting of electrolytes with the water loss and whatnot. So our fluid of choice for resuscitation in children is lactated ringers. And we basically assess adequacy of resuscitation with urine output is one of our big key indicators, along with vital signs. I wanted to add that under the toddler Blackboard tab, there is an additional article for information, for interest, as why we resuscitate children with lactated ringers versus normal saline. And lactated ringers just better matches the biomechanical composition of human plasma, and it has a very balanced electrolyte formulation, and it tends to sometimes when we fluid resuscitate with large volumes of normal saline, it can cause something we call hyperchloremic acidosis. And so we just have much better success with lactated ringers in children. And then there's also some interesting information on dressings under there as well. So let's practice a Parkland formula calculation. So we've got a 20 kilogram child with burns to 30% of their body. We're going to multiply 4 times 20 times 30. And that is going to give us 2,400 mils that we would administer that to that child in the first 24 hours. So you can see here, the biggest fluid shift happens in those first 8 hours. And so we give half of that 2,400 in the first 8 hours, then a quarter, 600, the next 8 hours, and the final quarter in the last 8 hours of 600 mils. So what we want to do is let's figure it out for the first 8 hours. This is the critical time period. So we're taking that 1,200 we would administer. We're going to divide it by 8 hours. So we know our IV is running at 150 cc's per hour. Then we're going to have to add on the maintenance fluids. And so for a 20 kilo child, we would use our maintenance fluid calculation, 1,000 for the first 10 kilos and 50 per kilo for everyone over that between 11 and 20 kilos. So we have 1,500 mils. We're going to divide that by 24 hours. That piece is not going to change. And that's 62.5 cc's per hour. And so we're going to take the 150 and we're going to add 62.5, and that's going to equal a total of 212.5 mils per hour in the first 8 hours. And then we would reassess. We're watching urine output, we're watching blood pressure, heart rate, circulation, all of those kinds of things. And then we would reassess and, might need to tweak it. Those are decisions the physician makes, but this is generally the approach we use. And in our case study, we will get a chance to do some calculation of the Parkland formula with a child of a different weight and different percentage of their body burned.